What I did was I focused on ALL, the gene arrangements from ALL, on three different genes, and I talked about the diagnosis, prognosis, and treatment for each one. So the three that I did was TCR, KMT, and ETV. Those are the three that I did today. Okay, so the TCR3BPX1 gene, this is in ALL. It is commonly found in children, and it is of intermediate risk. It is formed by a translocation, and well, there are many treatments that are involved with patients with TCR. This gene arrangement is a fusion gene that is classified as an intermediate risk group, though in childhood pre-BL, intensive chemotherapy is much favorable. This gene fusion transcript is generated by this translocation, which is found on chromosome 1 and 9. And this can be detected cytogenetically and by RQ-PCR. The PCR can be performed using standardized primers and single-round PCR. This also includes the 15-minute denaturation stage, and they can then be further analyzed by real-time PCR. The diagnosis differs on those of different ages, gender, WBC, that is the white blood cell count, and the status of the central nervous system and the complete remission rates of the bone marrow. With diagnosing these gene arrangements, the best ways in order to uh, identify which gene it is, the best thing we can do, as scientists can do to reveal it, is by using fluorescence in situ hybridization and RQ-PCR, as well as it can be detected cytogenetically. If you do all three, you can get a more confirmed answer on what exact gene is being detected in the body. Also, you can do molecular testing that will, or molecular targeting that will show you exactly which gene arrangements or which gene fusions are present in the patient. During the prognosis of this of TCR, it is quite difficult to obtain consistent results. For a positive prognosis, the patient should be younger than 10 years of age, presenting a low white blood cell count, and a declined presence of MRD following chemotherapy is completely necessary. The lower the MRD, the better it is for a more positive prognosis. This translocation is known to be the most common genetic abnormality, and these cases express a precursor B cell that is a common immunophenotype and are CD34 negative. These cases obtain molecular remission post-induction chemotherapy or either minimal residual disease. These patients with MRD negativity were found to be significantly recuperating while increasing their rates of survival. During the prognosis, there are many things to identify on a person to be able to know whether it would lead to a effective treatment plan or it will lead to a more vigorous treatment plan. With seeing the prognosis and the signs and symptoms of the present disease, you can decipher whether or not if the person would recover sooner rather than later, or you will be able to decipher what kind of treatment plans you can carry out with this specific patient. You will look at them based on their age, based on their gender, and see which one would fit into which category for treatment. A good prognosis is very, very important. And with dealing with leukemia, every patient is looked upon for MRD. MRD is one of the most important factors in prognosing and giving a treatment for a specific disease. For this treatment with TCR, most patients should undergo induced chemotherapy, which is one of the most common forms of treatment in this case. And the downside is that there can be relapses involved after treatment, and sometimes these relapses can be good, sometimes it can be bad, but in most cases, these relapses lead on to other diseases which have fewer treatment plans, or could be more vigorous or could be more chronic. So it's always a gamble to take with these with when you have these genes. To study more effective treatment options for this, leukemia from relapse patients allowed a molecular study of pathogenic progression. With drug sensitivity, scientists have identified this specific drug. I do not want to try to pronounce it. I might make a fool of myself. This drug is the most effective treatment for the TCR gene. With testing for this gene and to know how to treat this particular gene, they use bone marrow from those patients that have relapsed from their previous treatments, and this allows doctors and scientists to identify what would be the best way into completely annihilating this specific gene fusion, and by successfully treating a person so that they may not relapse, and so they may not be reinfected or affected with any other chronic diseases. The next one we can focus on is KMT2A-AFF1. This is not as an immediate risk as TCR. This is, it has a more positive diagnosis and prognosis available. And with this, you can see on the BLL chart, it's right on the top. And this has, if you have a positive MRD, everything else goes quite smoothly to detect this gene and to treat it as well. The best treatment for this, as you can see, is HSCT, hematopoietic stem cell transplantation is the best way to treat this gene successfully. This is a fusion gene that is produced from the translocation with a chromosome 4 and 11 involved. It occurs mainly in children or patients with pro-BL. To be able to diagnose the specific gene arrangement, conventional chromosomal studies of fluorescence in situ hybridization can be used. They could be different colors, probes, or dual colors or fusions that lead to this detection. Chromosomal microarray analysis, show it possible to detect heterozygous deletions in the AFF gene region. This strongly suggests a cryptic fusion, but by the extensive utility of mate pairing sequencing, structural abnormalities can be resolved using the mate pairing sequencing, which can provide a high quality resolution and enhanced accuracy. With diagnosing this specific gene, it is very important to know which gene is found in a patient. The best way to detect these type of genes is by fluorescence in situ hybridization, and like this, you can see which genes are involved, which type of fusions are formed, and how it is affecting a person. It can be detected right upon on a chromosomal level, and you can see exactly how this person is suffering. You can see different signs and symptoms that this person is dealing with, and you can be able to see what types of treatments would be the best treatment for this specific person. This gene is usually associated with a poor prognosis, which means that sometimes there aren't that many signs and symptoms that can decipher what exact gene you are dealing with or what exact fusion you are dealing with. So that makes it a positive, a very poor prognosis, because you do not know how it will how it is affecting the person until it is absolutely um, on the worst side. So it's very difficult to capture this gene at a very young stage or a very early stage. You won't see much of the signs and symptoms. And this prognosis usually depends on the age and the white blood cell count. The MRD negativity is an important factor. The survival rate is usually an overall of 5 years or more for those undergoing HSCT. With this gene arrangement, if the MRD is negative and the levels are low, then there is more scope for treating this patient with this gene rearrangement. When the MRD is positive, it will make it more difficult with a more vigorous treatment with a much lower rate of survival and a quality of life. The treatment includes the hematopoietic stem cell transplantation, which is the most effective. Induction chemotherapy can be used for certain patients with this case, or there are certain drugs that that can be certain treatment regimens, but the best way to be able to take this gene arrangement right out is by undergoing hematopoietic stem cell transplantation. With the stem cell transplantation, you are given a new lease of life. People are able, instead of having 1 or 2 years left to live, you can significantly live more than 5 years. You can live the rest of your whole life just as normal by undergoing this procedure. The drugs are one thing, but this procedure of the stem cell transplantation is a whole different scenario. The ETV6 RUNX gene, this gene is one of the positive gene arrangements when diagnosed with leukemia, because this gene has more favorable conditions rather than the others. This gene is detected by fish by fluorescence in situ hybridization, and as you can see, you can clearly see which chromosome it's on. You can see which gene regions, all on the fluorescence hybridization. And they also show how these two fuse, the ETV and the RUNX genes, they end up fusing, and that's how they come about with this fusion. And they continue making repeated copies of itself. This gene fusion is diagnosed with the B-cell precursor acute lymphoblastic leukemia, most commonly with children. It is associated with an excellent outcome, meaning the survival rates are high and patients with this arrangement can be cured. Children that are younger than 10 years of age with low MRD and attaining therapy with these genes are particularly favored. These translocations are usually revealed by the metaphase fluorescence in situ hybridization. So if anybody is diagnosed with leukemia and they are said to found to have this specific gene, it is usually good news for them because there is scope for improvement and there is a hope of fully being treated by from this specific disease. It helps with finding a treatment and finding a new lease of life. The prognosis, it is found on the specific translocation on chromosome 12 and 21. The prognostic variables include MRD and additional cytogenetic abnormalities. These variables are revealed through a FISH or by RQ-PCR. This gene arrangement is heterogeneous, and this can mean that if other abnormalities are surfaced, it could lead to an unfortunate outcome or even the opposite, but it is often associated with a good prognosis. This gene can be seen in the early stages. You can have signs and symptoms or other genetic abnormalities that are surfaced. Um, Certain genetic abnormalities or certain genetic mutations that are found to be surfaced through with this gene can either be a good thing or a bad thing. Certain times it works in favor towards the treatment. Certain times it can um, lead to a much longer treatment, or it can lead to bad news. But in most cases, it is a fortunate outcome, and as it is associated with a good prognosis, a good diagnosis, and an overall uh, good treatment plan. The treatment for this is usually chemotherapy. It is the first line of this treatment, but as you progress more, if chemotherapy relapses, you can always go for a HSCT, that is a hematopoietic stem cell transplantation. And yeah, with this enzyme, you are promised a high quality of life, a higher survival rate, and a much higher chance of survival. This gene is one of the most positive genes that can be detected with someone with leukemia. From all of these gene rearrangements, I have found out that most of them, their treatment plans include induced chemotherapy and as well as um, hematopoietic stem cell transplantation. With a stem cell transplantation, you are able to allow a person to start off afresh, to be born with a new perspective, and they can very well be treated in the long term and hopefully in the best terms to be eventually cured of their disease.